Jones. I'm the Healthcare Project Director at the Green Mountain Care Board. It's my pleasure to welcome you all to this webinar as part of the Vermont Healthcare Innovation Project's Core Competency Training Series for frontline care managers. Today's webinar will cover a critically important topic: domestic and sexual violence, the effect of violence on people's lives, and screening for violence. So I'd like to start with just a couple of brief logistical points. You will see a screenshot on this slide of your webinar control panel. You each have one of these, and it's your tool for participation in today's webinar. Under the heading Audio, in your control panel, you'll see two options: telephone and mic and speakers. By default, the webinar will connect you to your computer's audio. If you'd like to change this, just click on the telephone button and you'll be provided with call-in information. All participants will be muted for the duration of today's webinar in order to optimize our sound quality, but we do hope to engage in robust dialogue. So you can pose your questions by using the chat box in your webinar control panel. We also want to notify you that this webinar is being recorded and will be made available for future training purposes. So now I'd like to introduce our presenter. Yael Lipton is from Primary Care Development Corporation from New York. PCDC is a nonprofit organization that's developed and delivered nationally recognized training. And Yael has been a lead trainer for our core competency training for frontline care managers. So many of you have had the pleasure of meeting her in person. She's a master certified health education specialist and works as a lead trainer and curriculum development specialist at PCDC. She's been creating, directing, and evaluating health education programming for over 15 years. So it's my pleasure at this point to turn it over to Yael for this very important training. And thank you all again for being here.
Have a good weekend.
So we're gonna thank you all for having me. For those of you who I've met, some of the names are familiar. It's good to be back on the line with you. So there's actually quite a bit of noise on the phone. I'm wondering if someone's not muted. Okay, good, that's better. All right. So just quickly, I want to go over what we're going to do in the next 40-45 minutes. I'm going to explain the prevalence of intimate partner violence in the U.S. and specifically Vermont. We're going to talk briefly and quickly about the cycle of power and control in intimate partner violence, explain how it affects physical and mental health long after the abuse ends. We're going to list barriers for patients in accessing services, resources, and screening. We're going to talk about why screening in primary care and other social services is so important. We'll talk a little bit about best practices for screening, and then I'll give you some resources that are local to Vermont that probably many of you know, but if you don't, it seems like you've got some great stuff going on in Vermont to help you in this topic. So next slide. So what I want to ask people right now is, in your control panel, there's a little icon of a hand, and I want people to respond. Put your hand up or click on that hand if you've ever been asked by a healthcare provider about whether you are experiencing abuse or violence in a romantic relationship. So if you have, raise your hand. Okay, so we have, it looks like less than half of you. All right, so one other question. Now I want you to put up your hand if you've been asked by a social service or other type of provider, whether it was a therapist, an occupational therapist, a physical therapist, someone else who was helping you with something related to your health. Okay, so it looks like, again, just a few of you. All right, so this is what I expected, and this is pretty common. You know, I'll just tell you a personal story. I only once in my entire life have been asked by a healthcare provider if I was experiencing any type of violence. And the way that she did it was, first of all, she asked me if I had a boyfriend. So immediately she assumed that I was heterosexual, and I told her at the time that I did. And then she said to me, "And you feel safe in your relationship, right?" Well, luckily I did feel safe in my relationship at that point, so I said yes. But that was all I've gotten, you know, my entire life, and it sounds like some of you can relate to that as well. So let's talk about why that is and how we can change that. So next slide. Next slide. All right, until they advance the next slide, I'll just keep going. We're going to talk about, there we go, we're going to talk about how common or prevalent intimate partner violence is in the U.S. and Vermont. And just a quick note here that even though on the title slide we use the term domestic violence, we don't really use that term so much anymore. And the reason for that is that it has a legal connotation, and it really has in the past has referred to people who are married. And as we all know, you know, violence happens in all kinds of romantic relationships and contexts, both heterosexual and homosexual relationships, and people don't have to be married. So next slide. So the takeaway from this, as you look through these statistics, is that it's really common, and it's really more common. So just a quick anecdote about some of this, because when I started doing this work, I read these statistics, and it was a little bit hard for me to believe. I was kind of skeptical. I've been teaching human sexuality to undergraduates at a New Jersey university for many years now. The final project that I ask them to do in class is to write a sexual self-analysis. The way it works is that I provide about 20 to 30 questions that are about everything related to sexuality, and they just have to pick a few that they can really dig into and answer and talk about their lives. Over the years, I've received dozens of papers from students who talk about being assaulted and abused in their papers, and telling me in the papers that it's the first time that they have ever talked about it to anyone. So, you know, even though, again, these statistics do seem overwhelming, from my own personal experience, they seem pretty right on. And, you know, it's been really overwhelming to me, really sad and very scary. So that's how I really got interested in this topic. Next slide. So in Vermont, the CDC does collect some statewide data, but the way that data is collected locally in your state is mostly through the number of people who access services and police reports. So you can see here that, you know, a third of Vermont women have experienced some form of intimate partner violence in their life. In the last report, for the crimes report that I could find, rapes had increased, as well as assaults. And these are the numbers here of the people who have been served by sexual and domestic violence programs, and 2003 was the most up-to-date that I could get. So you can see that it's really a lot of people. However, we also know that most people who are experiencing violence don't actually access services, and even for the ones that do, they were likely experiencing, you know, violence for years or a certain amount of time before. So next slide. So this may be familiar to many of you, and I'm not going to spend too much time on it. This is just a quick reminder about the cycle of power and control. And it really helps us understand the different tactics that abusers use to gain power and control over their victims. And we'll go into a couple of these in specifics in a minute. Okay, next slide. So intimate partner violence is a pattern of coercive or violent tactics used by one partner, again, to establish and maintain power and control over another. It can be physical, it can be economic, it can be sexual, and it can be psychological. Partners include all of these different people. While this presentation is mostly focused on women survivors who are victims of their male romantic partners, it's really important to say that unfortunately, intimate partner violence happens just as much in gay and lesbian and bisexual relationships, and the tactics are really similar. However, people who are survivors are often, LGBT survivors are often less likely to report for many reasons, and there's often not as many resources for them. However, I happen to know that in Burlington, that your Pride Center is run by someone who I actually used to work with in New York City, who did work around violence, and she's an amazing woman named Kim Fountain. Maybe some of you know her. And again, while intimate partner violence is most common in women between the ages of 16 and 24, and I know that most of you work with people who are older, the effects of the abuse, they stay with people and they last for years and years longer. So even though maybe the people that you're not seeing don't fall within that age range, they may be experiencing effects from, years of violence. So next slide. So again, just a little bit more numbers to ground us. Right now, 1 in 10 high school students has reported being hit, slapped, or physically hurt on purpose by a romantic partner, and 24 people per minute are victims of rape, physical violence, or stalking by an intimate partner in the U.S., and that's over 12 million women and men over the course of a year, okay? And again, here we see that men are actually survivors and victims as well. Next slide. So these are just some of the physical tactics that abusers use. If you factor in that some of the people who are being abused have chronic health conditions in which sleep, stress, and medication play a really important role, this gets very scary very quickly, and the stakes, become even kind of higher. Again, these are the things that oftentimes people are seen in the emergency room for, and the things that we can kind of understand the most, but certainly it's there are other forms. So let's look at those. Next slide. So there are obviously a lot of sexual tactics. I want to pause on the fourth bullet, which is this jealousy thing for a moment. I'm sure there's some parents out there on the line and parents of young people and teenagers. So many of my students would talk often about how their new partners would do things like, pick them up from school or work and then drive them to their next destination. They would always ask them to text them as soon as they got to where they were going. And, this, of course, seemed really sweet and in the beginning, but just as a heads up, this is always a really big red flag that this can quickly turn into, controlling and this obsessive behavior. So the next slide. So this is often a type of abuse that doesn't get a lot of attention, but it's very efficient, meaning it works really well. When people lose control of their finances, even thinking about getting out or leaving doesn't, makes it much harder, or it requires a lot more preparation and effort. So just as an example, I like to, you guys all know I like to tell stories for those of you who know me. I had a woman who worked for me at an old job, and she was fabulous. She was a health educator, and she started to come in late to work a lot. She had, lots of kind of different excuses. There was a lot of, her family was sick, and she had to run to the emergency room. And I was really, understanding in the beginning, and then people in the clinic, came to me and said, something's going on. She's not as good as she used to be, and she has a lot of excuses for things. You need to talk to her. So we had a pretty good relationship, and I sat down and I talked to her, and I said, what's going on? Because you really need to show up on time. And it was then that she told me that her girlfriend, she was being really abused by her girlfriend, and one of her girlfriend's tactics was to turn off her alarm or hide her phone in the middle of the night so that she wouldn't wake up to her alarm, in a direct effort basically to sabotage her job, so that this woman would become dependent on her partner for money and daily living and life expense. So it's a really efficient way to gain power and control over someone. And again, it's always seemed, sometimes in the beginning it seems sweet, things like, baby, it's all good, I have enough money, you don't need to work anymore, or I'll handle the finances, we'll just put everything into the same bank account. Again, seems really like a good intentions in the beginning, and then obviously is used later with not good intentions. End of the story is we actually ended up, having her back and supporting her, and she, about 6 months later, was able to leave and left the state to get away from this woman, and she's doing really well. So just to let you know. Next slide. So again, these are often other tactics that are overlooked, and these are things, that stay with survivors long after they have left their partners. Just in terms of the intimidation, I just want to say that for the LGBT populations, this can be especially effective, especially if people are not fully out to everyone in their community or their family. They're often threatened with being outed, as well as people who are, maybe living in the country undocumented. So it's a similar tactic. Next slide. So I'm going to read you a quick story that really illustrates the long-lasting effects of intimate partner violence, and this is a true story, and you can follow along with me. So next slide. Sarah was sure she had left her violent past behind. Her first husband, a high-powered business executive who during their 10-year marriage had pounded her head against walls, sexually assaulted her, and nearly strangled her with a dog leash, was out of her life. She'd gotten a divorce, finished college, become a successful consultant, worked intensively with a trauma therapist, and married an old friend with whom she felt safe. Gradually, the symptoms of her previous torment eased. The residual headaches from the head injuries disappeared, although she still remembers the sound of her skull hitting the kitchen walls and floors. There are still black holes in her memory. She can't coherently recollect the years from her mid to late 20s, the period when the violence reached its height. But the worst of the terrors are over. I no longer suffer from PTSD at night, she says, remembering how she would sleep in her horse's stall to hide from her then-husband's drunken attacks. Now remarried, I no longer have a hyper-startle response if my husband walks into the room behind me. Next slide. In her mid-30s and wanting to start life anew, she was ready to be a mother. But for reasons her doctor initially didn't understand, Sarah struggled to carry a baby to term. After 6 miscarriages, a doctor finally suggested that head trauma could be a factor. Neurological damage from repeated brain injuries had disrupted the hormonal balance she needed to deliver a healthy child. My endocrine system just hardwired the violence into me. After all of the work I have done in the past 14 years, getting away from the men who were abusing me, she was also abused as a child, and getting my mind in a good place, I really thought I was there. But there's a whole other layer of this legacy, and it wasn't until I was safe that those symptoms started to emerge. So this is really common with survivors of violence. The physical and psychological problems that they experience long after the abuse has stopped is rarely recognized as being from the violence. Next slide. So what are some of those effects? Certainly there's mental health problems, there's cardiovascular problems, there's chronic pain, arthritis, respiratory issues, and gastrointestinal problems. Next slide. So just to give you some context, women who experience IPV are 80% more likely to have a stroke, 70% more likely to have heart disease, 60% more likely to have asthma, 70% more likely to drink heavily than women who have not experienced IPV. So certainly in the work that you're all doing with people with chronic conditions, violence, is probably maybe a big contributing factor to it. Next slide. So, again, I'm not a scientist or a medical doctor, so I had to really try to understand this. But what I learned is that violence can impact brain function and really even the DNA. So what the third bullet is really saying, because again, if you're like me, I didn't really understand it when I read it, is that women who have experienced IPV are more likely to get sick, age faster, and have a compromised immune system. Even women who left abusers years before, they actually often have the physiological profile of women who are 10 or more years older, which again to me is really, really shocking. Next slide. So what are the costs? So survivors actually spend about 20% more on medical care than non-survivors, and annually we attribute costs from assaults, from IPV overall, from $25 billion to somewhere to $59 billion. Some of the cost is from old injuries, some of the cost is from living in terror so long. Most of us know the dangers of chronic stress and of always being in that fight or flight mode, and it just makes people sicker. So next slide. So how do we know when someone comes to us? And again, I know not everybody here is a healthcare provider, but certainly the people you're working with, tell you how they're feeling and what's going on with them. So what are some of those things that may raise a red flag? So headaches are a big one, a lot of chronic pain, back pain, a lot of digestive problems, and appetite disturbance. So the main problem for the medical and social service community is that most people who are coming to primary care or into our offices, they're not saying, I have back pain because I was assaulted so many times. Their complaints are the kinds of things that we actually see as routine and normal for many women. And again, some of it is not related to violence, but some of it really is. I've read some research that says that 1 in 10 women who go to primary care in a given day are actually there for reasons of violence. Okay, next slide. So obstetric and gynecologic, people often report painful intercourse or sexual dysfunction, meaning that they just don't have, the desire, like they used to, or as other women may. Injuries during pregnancy, sexually transmitted infections and HIV, and also urinary tract infections. Next slide. So mental health, lots of depression, anxiety, PTSD, and not being able to sleep. Eating disorders. A majority of women with eating disorders have been sexually assaulted or abused as children. Abuse of drugs, alcohol, or tobacco, and clearly thinking about suicide or attempting it. So next slide. So again, the assault injuries are things that are the easiest to spot and raise the biggest red flags, and usually will often happen in the context of an emergency room. So we can just go to the next slide. So a couple of quotes from some survivors about alcohol and drugs. I started smoking dope because I couldn't take it anymore. He got me hooked on heroin. That's another, abuse tactic. I had an alcohol problem before I met him. He said, nobody will believe you. You're a freaking addict. Okay. Next slide. So a question I get a lot is, why do people stay? I get this question from my friends and family when I talk about this stuff. I get this question from people I work with. And there are many, many reasons. Some of the most common ones are actual safety. So people fear death when they leave. Leaving is actually the most dangerous time for women. If you think about when you watch kind of your local news or read your local newspaper and there's a story of a woman who was found, dead in her home or on the side of the road, usually what follows that is, her estranged husband or her estranged boyfriend or her ex-lover, they're looking for them for questioning. And it's often the most dangerous time. That's why people don't actually leave. There's an emotional component to it. There was love there, right? Nobody got punched or kicked or stabbed on the first date. If they did, there wouldn't be a second date. So there has been a relationship that's been established and an intimacy, and people still remember that. So there's hope, that could come back. Immigration, again, when abusers are using, threatening people with calling immigration if they leave. Sometimes there's some cultural stuff about keeping a family together. It's more important for the kids to have, two parents as opposed to one. Again, all this financial stuff, or how am I going to survive? There's also a lack of shelters and other services, so really sometimes there's not somewhere for people to go. Child custody concerns are a huge one, and oftentimes people are really intimidated by the criminal justice system, and I don't blame them because I find this to be the most confusing aspect of all of it. So next slide. So one thing we do know is that survivors want to be asked. When we ask survivors, do you want to be asked, and who do you want to ask you, they overwhelmingly say people in the healthcare system. They want their providers to ask them. Next slide. So how are we doing in primary care? Unfortunately, we're not doing very well. Only 15% of women with a history of IPV had any reference to violence in their medical records, and only about 10% of primary care providers routinely screen during new patient visits or periodic checkups. Organizations that work on violence, they report that they get very few referrals from the healthcare world. Often when there is a disclosure in primary care, the response is inappropriate. And oftentimes, again, not blaming anyone, oftentimes doctors and nurses and other people in primary care really have not been trained, so they just don't know what to do. So what often happens is that women present with the symptoms that we just went over. They're treated for those symptoms. Maybe they're given pain medication, maybe they're sent to physical therapy, and they may get a little better for some time, but often never fully, because the root of their symptoms, the root of the problem, is not addressed. Next slide. So what are the barriers? Why don't providers ask? So there's lots of reasons, and there's even reasons that even when we do ask, people don't tell. So we'll talk about those as well. These are some of the barriers. I've often heard from providers that there's no time. There's so many things to do in a visit, they just can't add anything. Another personal story, I was working on a project for Planned Parenthood, actually, on the relationship between violence and HIV. And I went to my primary care doctor for a checkup, and I had some articles that I was reading. And she walked in, and she saw what I was reading and asked. And so we started talking. And she said to me, I don't ask because I don't know what to do if someone says that they are, experiencing violence. So, I thought it was great that she said that because, she clearly, admitted that she didn't know what to do, but also kind of sad. So next slide. So sometimes survivors don't, or victims don't tell even when they are asked, right? They're scared that they're not going to be taken seriously. That's what they've been told. They're scared that their abuser will retaliate. They don't have housing or money. There may be, language barriers. They're scared of their children being taken away. This is a really complicated one. Next slide. So let's talk about ideally when people should be screened. So any new patient or client should be screened upon any type of annual visit in primary care if there's a new chief complaint, especially if it has anything to do with those things that we went over before. Anytime there's a new intimate relationship, and also during the prenatal time. I'm not sure how much people know about this, but oftentimes violence escalates when someone gets pregnant, or it can even start in that time. Some of the reasons for this is that when women are pregnant, we're often really focused on taking care of ourselves for the baby, and oftentimes a romantic partner we're not able to pay as much attention to the romantic partner. That makes an abuser angry, as well as it's another thing to use against the person, right? If you don't do, X, Y, and Z, I'm going to kick you in the stomach, or, I'm going to report you to immigration, and then, your child will be taken away, or things like that, okay? Next slide. So how to screen. So these are just some general guidelines. We need to do it in private. I wanted to, some of you who were in our core 3-day training, when we did our values clarification exercise, there was a statement that we talked about around if women request that their male partner should be present during all of their visits, that request should be honored. And I remember that a lot of people believed that and said that they agreed with that. And the reason is that because that was patient-centered, and if that's what the person wants, then we should respect that. And while I generally, agree with that, violence is a reason why we actually always want to get women, actually anyone, any person, alone for a certain period of time. One, to screen for it, and also, for other reasons as well, even if there's not abuse, but just to talk about things that you don't necessarily always want to talk about in front of a romantic partner. But certainly violence is a big one, and most of the women's health organizations like Planned Parenthood and places like that, they have a very strict policy of allowing a visitor or someone to accompany you for a time, but then there's always a private time with the provider. It's okay to put these questions on a questionnaire or a health form, but we still need to ask, even if it's not disclosed. And here are just a few suggestions for ways that we can, phrases that we can use, and ways that we can just kind of let everyone know that we ask everybody. Next slide. So how not to screen. So we said this already. When there's another person who's with that client or patient, looking down at our notes or at our computer, my same provider, my primary care provider, the one who said that she was scared she didn't do if someone said they were experiencing violence, she also told me several times, I used to take care of patients, and now I just take care of the computer. And that was her way of telling me when she was in a visit why she wasn't looking directly at me. And she was clearly upset by that, so I thought I wanted to add that. And then again, the provider who asked me, you feel safe in your relationship, right? Because we all know what kind of answer you're going to get when you say that. So next slide. So what to screen for? Current and lifetime experience with abuse, physical, emotional, and sexual. I would even add the other ones, financial as well. Next slide. So here are some questions there's just 4 or 5 of these that really can be put into any type of assessment that you're doing with people. Have you ever been emotionally or physically hurt by a romantic partner? If so, by whom? Within the past year, have you been hit, slapped, or otherwise physically hurt? If so, by whom? Within the past year, have you been forced to have sex against your will? Are you afraid of your partner? Or does your partner do anything to hurt you or make you feel bad? Again, I really like the last one because that one opens it up to some of the things that are not like the financial stuff, the threats and intimidation. It's easy to ask about the physical stuff, or it's easier, but the last two questions can really help you understand someone's situation and what their abuse looks like if they are experiencing it, because no two abusive situations are the same, unfortunately. Okay, next slide. So I just put this on here. The CDC has this fabulous guide that you can download for free or send away from. There are a ton of assessment instruments in here for use in healthcare settings. I use this a lot, and I would say that it can be used, it's not just for healthcare settings, it can be used in other places as well. And they're all evidence-based, and there's a lot of them. And so I didn't put one on here, and the reason for that is because there really is no one agreed upon by a majority of organizations doing this work. So I encourage people to go online and get this and take a look and see what makes sense for your organization. Next slide. So what do you say if someone discloses? So I'm sure a lot of you know this already, but it's really important to tell people that you believe them, that it's not their fault, that no one deserves to be treated that way. Perhaps you're sorry. You could say you're sorry they've been hurt. You're concerned about their safety. I care about you. Asking if they want help and then directing them to those resources. You don't have to be the intimate partner violence specialist or expert. Just know a couple of places locally where you can send people, and just like all the other care coordination work you're doing, know those people at those places. Try to build relationships with them so that you can get to them when you need them. Okay. Next slide. So what not to say? And I know this sounds silly, but I've actually heard these things from different people in my years of clinical work. Avoid victim blaming, right? Like, what did you do to really upset him? Or how could you stay with that person? What you're telling me is so horrible. How could you stay? You really, really should leave. Again, many of us think that, and it's okay to think that, and that's okay to say to our friends or our family, but in a professional setting, that's, again, really blaming. It's a victim blaming phrase, really. Next slide. So what do you do? So I always thank people for telling me, and I thank them. I say, thank you so much for trusting me with this information. I'm really concerned about you, and I care about you. You have to assess immediate safety. Sometimes someone will disclose in a time where they are particularly scared and that they do fear for their life, for lack of a better way to say that. So you need to ask if they need somewhere to go. And again, we need to know where those places are, but we do need to let them take the lead. Only they know what is the safest or most dangerous in that moment, okay? We have to refer out, and it's really good for us to know some general stuff about the legal considerations in your state. Next slide. So you can Google safety planning and in intimate partner violence, and again, you'll get tons and tons of resources and 3-4 page long tools to help people create safety planning. These are some of the things you want to think about immediately, though, if someone is in your office at that moment, are there people they can talk to who they trust that can help? Is there somewhere they can go that they know is safe, a friend they could stay with? Is there someone who could potentially loan them some money, things like that? Considering what they can do in the moment to increase safety. So this might sound really silly, but if there's a weapon in the house, do they have access to it? Can they hide it? is how will they literally get out of the house if they need to? Is it through the basement and through a window that would fit them? Is it the back door? Things like that. Memorizing numbers that they might need. Again, another tactic is going to be for abusers to take away a cell phone or destroy a phone. So people should work on memorizing numbers. If there's children involved, they need to talk to the children about safety. And people really need to prepare a go bag, and it could be hidden somewhere. It could be at a friend's house, and it should have things like keys, money, bank cards, things like that. A phone, if possible. Any legal documents like IDs and birth certificates, green cards, orders of protection, some clothing, medications, food, and phone numbers, as well as, it's not on here, but as well as food for pets. Oftentimes I've heard people don't leave because they're scared for their pets, or there's a shelter that they scoped out or a service that they scoped out, but they don't allow pets, so that actually prevents people from leaving. And I think we even saw that in a different context, right? During Katrina in New Orleans, a lot of people didn't want to leave their pets. Okay, next slide. So what else can you do? I think the most important thing as a care manager is really leaving the door open and continuing to ask and believing people. On a side note, you can certainly advocate. You want to learn the law a little bit, right? How does one get an order of protection? What services are available? Partner with a local organization that specializes in this and bring them in to talk and train others. You guys you have so many great resources in Vermont, so use them and you're good about it. And then just keep talking about it. That's what I always say. Just keep talking about it. So next slide, we're almost done. So these are some of the Vermont resources that are available to you. You have this great organization, the Vermont Network Against Domestic Violence and Sexual Assault. On their website, it links to all of their local programs throughout the state, and I believe it goes by county. You have a statewide domestic violence hotline. You have a sexual violence hotline. And again, the Pride Center of Vermont, the Safe Space program, that's specifically for LGBT, populations. And again, I can say firsthand, the woman who runs that is amazing, and I learned a lot of what I know from her. So we were sad to leave her, have her leave us in New York, but happy that you got her in Vermont. Next slide. So again, this is a little bit hard to see, sorry about it, but this is just taken from that website I was telling you about, and you can see that it's really by different counties. Next slide. So other national resources, Futures Without Violence is a fabulous organization that has tons of online training resources and safety planning resources and research. There's a national domestic violence hotline and certainly Centers for Disease Control. And I think, oh my God, I'm like exactly on time, 44 minutes, 16 minutes for questions. So I know that was a ton of information really, really quickly, but I'm happy to answer questions. So, okay, so we know that IPV can cause brain injuries which often go undiagnosed. Have you seen any data on this? If I look back to my presentation where I got the data on the health effects, I could probably find some, but off the top of my head, I can't exactly tell you where to look.
But just a reminder for folks to, if you have questions, there's a questions bar on your control panel, so just go ahead and type your questions into that spot.
Yeah, so I would have to look, but I bet there is some. Again, I think one of the problems is always whether or not people are disclosing that, that happened to them, which I know, doesn't always happen. So, okay, so the next one is, our abusing partner may have tracking on their partner's phone. Yes, absolutely. I think that's more of a comment. Technology has allowed for many awesome things in life, but it has also allowed a new avenue for abusers to control and manipulate and keep tabs on their partners. So absolutely. In our nursing screening, we tend to ask, do you feel safe at home and in your relationship? Yeah, I think that's fine. I guess I would just say, no, I think that's a fine question. I assume that if someone says no, that there's follow-up questions, instead of just well, why not, and oftentimes we have to kind of say a little bit more to get people to talk about what theirs looks like. Do you mind showing the screen again with the Vermont Resources phone number? Sure. So I think that would be Holly, if you can go back to it. You can also find it better on the, what did I say it was called? That awesome site. Work Against Domestic Violence and Sexual Assault. If you go onto their website, you will find a lot of really, really good stuff on there. Are there any other questions or comments?
It goes out after.
Yeah, we'll make sure we send the PowerPoint out, or we will have it posted on the Vermont Healthcare Improvement Project website. So.
And I wanted to just say one more thing, because maybe some of you have been participating in this, but when I looked at the Vermont Network Against Domestic Violence and Sexual Assault, I noticed that they have a healthcare initiative where they are trying to partner with healthcare organizations, primarily primary care, to improve screening and increase how many healthcare providers are screening. So I'm just wondering if some of you are aware of that or are participating in that. And it seems like a great program and a natural fit, clearly, for care coordination.
Okay, we'll give it another minute to see if there are other questions, but in the meantime, I just want to thank you, Yael, so much. What an incredible amount of information, some really good Vermont-specific information as well, and you clearly have very rich insight into this incredibly important public health concern. So I want to thank you for sharing your knowledge with us. I also want to note, and you'll see on the final slide, that there are a couple of upcoming training opportunities. The first is our next webinar in this series of webinars, and that will be on August 12th, again from noon to 1 p.m. And this time our colleagues who have been providing our disability-specific training will be presenting on sexuality and reproductive health. And the link, I believe, has already gone out for that, or will be going out. It's been open, so it will be going out soon, and you can have the opportunity to sign up for that. We're going to have a second August webinar at the end of August, so stay tuned for information on that one as well. We do have in-person training opportunities in August, but it's the first 3 trainings that PCDC has provided, the in-person trainings. These will all be in Burlington on consecutive days, August 17th through 19th. And we do still have some slots available in those trainings. So if there are folks who either missed the prior in-person trainings from PCDC or haven't attended any of the trainings for frontline care managers, we encourage you to visit the VHCIP website, or again, look at, there's a link here, and feel free to sign up for those. We do have not a ton, but a few slots left in those final PCDC in-person training days. So many thanks again. I don't know if what looks like we've received one more question.
So someone's asking what PCDC stands for, and for any of, yes, so we're Primary Care Development Corporation. We should all do better with not using acronyms as much.
Yeah.
I want to thank everyone. For those of you who know me from the in-person training, you know that that is more my comfort zone, and actually the webinar format is not my comfort zone. I feel least comfortable doing this type of thing. So thank you all for bearing with me through it. And I look forward to seeing some of you in August and September and later.
And we did get a question about whether previous webinars are available for viewing. Stay tuned. We are improving and revamping the website for the Vermont Healthcare Innovation Project. And when we have that website up and running, which should be in the next couple of weeks, we will at that time have the prior webinars available. So stay tuned for that, and good question. Any other final questions? Okay, I again want to thank everybody. We look forward to interacting with you again in future webinars and training events, and a special thank you to Yael and the folks at Primary Care Development Corporation for this outstanding training. Have a great rest of your day, everybody.
Thank you so much.
Take care.